This is a case of combined traction and rhegmatogenous retinal detachment in a patient who presented with rapid progression within 1 month. By the time we went in, it was a tabletop detachment, almost like a funnel detachment. Patient received intravitreal Anatvef couple days prior to surgery. Surgery started with identifying the retrohyaloid space. Obviously, there is incomplete posterior vitreous detachment. We cannot do posterior to anterior separation. In this condition, segmentation of the posthyaloid and separation sometimes need to be done from anterior to posterior. Spaces are identified. Multiple attachment were identified. Gentle isolation of the islands of traction was done. We can see clearly how the separation was done manually, and cutting off the anterior-posterior traction was performed. The detached retina slowly fall back. As we can see, the beauty of anti-VEGF prior to surgery, keeping the retina as clean as possible, with hardly any bleeding during the dissection. In combined cases like this, without enough countertraction, bimanual technique would be the best option. The detachment also helps to allow better clearance of the gel, as it created a self-indentation of the retina. Draining of the fluid should be done last after all the tractions has been cleared up. Heavy liquid was used as the third hand and helped to countertract the forces during further separation of the posterior hyaloid. Tannoscraper is the best tool to identify the remaining posthyaloid, as vitreoschisis is very common in diabetic cases. Tannoscraper is known to be firm on the vitreous yet gentle to the retina. Repeated staining was done using triamcinolone and even the blue dye to ensure there is no remaining vitreous and taut internal limiting membrane left behind. And finally, surgery was concluded with laser and silicone oil as endotamponade. Vision at post-op 3 weeks was 2/60 and patient is mobilizing well at home.